Howdy! My name is Kelly Johnson, and I work with the PEER program at the College of Veterinary Medicine and Biomedical Sciences here at Texas A&M University. And we've put together a series of training videos to help you with your educational endeavors. So today, two of our veterinarian technicians here at the vet school, Katy Waddell and Jennifer Hanke, are going to demonstrate the anesthetic preparations that they use for a dog.
Okay, so the first thing whenever we're presented with a patient for anesthesia is we have to make sure, yes, this is the correct patient that needs to have the anesthetic purposes. At A&M, all of our patients wear hospital ID bracelets similar to what patients are issued in human hospitals. On admission, they'll go around the neck, and their identifier case number as well as owner name and patient name will be on the neck band. So when I have an anesthesia request, I have a copy of my request. With patient name, I'm going to first confirm, yes, this is Fluffy, that I need to provide anesthesia for whatever procedure is required. So I've got my paperwork, I've identified my patient appropriately. With my paperwork, I've also had the opportunity to go ahead and read existing laboratory results. If there are any radiographs or any images that are available, we have those on computer records so that I can review those. I will do a physical exam, start with nose to toes, examine the patient. I will auscultate heart and lungs as well so that I know exactly what I'm starting with because I personally laid hands on this patient. Now that I've identified the patient, I've done my physical exam, Fluffy's going to go back to the cage and Jennifer's going to show you how to actually prepare your anesthesia machine so that we can safely provide anesthesia for Fluffy.
Okay, before we anesthetize our patient, we have gone over and done a physical exam on him. We've identified that he is the correct patient, reviewed all lab work, everything's good, we're ready to go. We must double check our anesthetic machine, check for leaks, make sure everything's hooked up, make sure we have oxygen and all the necessities. So we look at our oxygen tank, which is here. This is a 7,500 pound or 750 pound tank. You always take your valve and you turn it on. It's the same as anything else, righty tighty, lefty loosey. And this is your oxygen gauge. It can go up to 2,200 psi. So here is your oxygen regulator gauge. It tells you how many psi you have flowing through your oxygen tank into your machine. Then your tank connects into the back of your machine, which connects into your flow meter, which regulates the flow of oxygen you actually have going to your patient. So, out of the flow meter comes your tube that connects into the vaporizer, which regulates the amount of anesthetic gas, whether it's sevoflurane or isoflurane or whatever you might be using, which comes down into your rebreathing bag and your circuit, an expiratory and inspiratory circuit, which also has a regulatory gauge here so that you do not too much pressure and poundage into the dog's lungs and potentially pop their lungs. Which comes back out to, so your rebreathing comes into the inspiratory, out the expiratory. You need to always, before you use your machine, always check your machine for leaks. So what you would do is you would close your pop-off valve, turn your oxygen on, which I think I've already done, turn your flow meter on, let your gauge build up to about 20 psi because you don't want to apply more pressure than 20 psi into your patient when you have them hooked up.
She's going to close or obstruct the end of the breathing circuit so she now has a closed system.
Right, and that equals, my thumb equals an endotracheal tube into the patient. And we will get some oxygen here. Basically. There we go. You can see your bag. My bag is filling up. So we get up to about 20. I turn my oxygen off. My pop-off valve is closed. Squeeze our bag. We hear no leaks, okay? So simultaneously, I will open my pop-off valve, release the pressure off of my end of my circuit here to relieve the pressure in the machine, squeeze the rest out of the bag. Okay, we're ready to go. We also have connected to the machine, you have to have a scavenger system connected to the machine unless you have a closed circuit set up in your hospital. So this is what this tube comes down and it filters out excess anesthetic gases.
This is the soda-sorb canister here. You can see this is what we actually call the scrubber. It is on the expiratory side of the patient. Patient inhales the fresh gas, 100% oxygen with the anesthetic agent. When we exhale, it comes through the expiratory valve. It comes through your soda-sorb canister, which actually removes carbon dioxide so that your patient is not rebreathing carbon dioxide, which becomes toxic at specific levels. So that's another safety feature that is built into a rebreathing circuit for your patient. Okay, so Jennifer has positive pressure checked the machine. We've identified our patient. We would give premedication, whether it be an anticholinergic, which is going to preserve heart rate, depending on the patient's starting heart rate, plus some type of analgesic agent. That'll depend on what your veterinarian wants to use for a premedicant, as well as while we're providing anesthesia. Is this for diagnostic imaging, so it's not going to be a painful procedure, or is this going to be a surgical intervention where the patient's going to need more pain management? Once we've given the premedication, we're going to wait about 20 minutes, let the drugs start to work. Then we're going to clip and prep and place our IV catheter. So our premedication has dual purpose. It provides some relaxation, decreases stress for the patient for the manipulation for placement of IV catheter, as well as it potentially will reduce the amount of induction drug we'll have to give the patient in order to capture the airway. To capture the airway, we're going to use endotracheal tubes. We sterilize ours between every use, but this is a non-sterile one so that I can show you for demonstration. There are two different ways that you can actually check to see the correct size that you will need for your patient. My hands, after so many years, have learned to see, basically. So I can palpate the trachea of my patient and guesstimate in my head what size endotracheal tube I will need. Another way of doing it is you can measure the frenulum in between the two nares of the patient with the external diameter of your endotracheal tube, and that gives you a fairly close guesstimate of what size tube you'll need. We try to use the appropriate size so that if it's a small tube, we're not overfilling the balloon, which forms a seal, because that can cause tissue necrosis or tissue damage right there at the cellular level. The second thing I would like to do is make sure that my tube is an appropriate length. And to do so, I'm going to measure from the incisors. I want the distal or far end of my endotracheal tube to be right down at the patient's thoracic inlet, because I need to go past my cricopharyngeal area. But if I go too far into my airway, there's a possibility that I can have my tube in one bronchus and my patient will not oxygenate or stay asleep. So what we'll do is we'll just hold it up next to Fluffy, and this one is actually a very nice length for this patient. A lot of practices will not cut the tube. They'll just remark, well, on this patient I will not place the tube any further than 28, and you can see there are actual line measurements, demarcation, so you have an idea of the length of the tube. And 28 will be where I place my tube to the incisors before I secure it. So once our IV catheter is placed, we have measured our tube, selected the appropriate size, then I'm actually going to inflate my balloon just to check and make sure that I do not have any leaks in it. And a lot of times I will go, once I've selected that, I will go ahead and inflate that, get my catheter prep or my induction drug, come back, make sure that how many mils I have put into this balloon is still remaining and I do not have a slow leak. Okay, you always want to remember to deflate that cuff before you try to intubate your patient. So for intubation purposes, I also will use a laryngoscope as a lighted guide, a dry gauze with which to grab the patient's tongue to extend it further forward. And then we use roll gauze or soft cling bandaged material in which to actually tie the endotracheal tube into place. So if Fluffy already had an IV catheter and I was ready to induce, we've pressure checked this, I have the appropriate size bag and breathing circuit for the patient. Jennifer's holding Fluffy. We're going to go ahead and inject slowly because we're going to give just enough of the drug to capture Fluffy's airway. We don't want to slam him, give him too much. Start low, go high, because you can always give a little bit more. Sometimes it's hard to take a drug back. So we're giving, he's starting to relax. She's checking that by holding his top jaw and seeing how relaxed he is. Once he's relaxed, and she says, Katie, I think you can get it, I'm going to reach up, I will grab the tongue, pull it out of the mouth for Jennifer so that she does not have her hand in the dog's mouth going for the tongue, because that's how you can inadvertently be bitten. So the tongue is out, Jennifer's holding the tongue for me. Excuse me. I'm going to take my laryngoscope blade, I'm going to insert it all the way into the base of the tongue. I'm going to elevate my handle, and what that does is that actually opens up your airway so that you can see the arytenoids, which are also called your little vocal folds, and you'll see them open and close. And we're going to go in between the vocal folds with our endotracheal tube. So I can visualize nicely. He's opening his arytenoids for me, and I'm simply going to pass my tube into the vocal, between the arytenoids into Fluffy, and with the dummy, this is as far as this tube will be inserted. She's going to close the mouth for me. I'm going to go ahead and hook up some oxygen to him. If Fluffy were a patient with a history of vomiting, the first thing I would do once I had the endotracheal tube in place is inflate the cuff to form a seal. I want just enough air inflation to where I have a seal. I don't want to overinflate and cause pressure on the tracheal tissue. If he was not a vomiting patient, then I would go ahead and I would tie my tube in place. You may tie, depending on what you're doing as well as patient's anatomy, you can tie behind the top canine teeth to the top of the nose. If this is a patient where we're brachycephalic or we really have no nose, like a Boston Terrier, a pug, or a bulldog, you can move the tongue to the side so that you're not incorporating the tongue in your gauze tie, and tie to the bottom jaw. Be sure and tie it with a bow, so if you need a quick release, it's available to you. Now the patient is intubated, cuff is inflated, the tube is secure, so Jennifer's watching him. I have oxygen in my bag. She's going to palpate a pulse for me and say, yes, Katie, we have a pulse. I'm going to go ahead and turn on my vaporizer, depending on which agent I'm using and how asleep is Fluffy, to my vaporizer setting. We're going to give him a breath or two. I'm not going to squeeze my bag and take my inspiratory pressure any higher than 20.
Well, we hope you enjoyed that video, and on behalf of the entire PEER team, we wish you the best of luck with your educational endeavors. Don't forget to check out our website at peer.tamu.edu for other training videos and free resources. Thanks again, and we hope to see you soon.